Good afternoon, everyone. My paper is on the topic Safety and Efficacy of the Newer Topical Anti-Glaucoma Drug, Netazodil, a retrospective study. I have no financial interest. Netazodil, a novel topical anti-glaucoma drug, acts by reducing the intraocular pressure by increasing the conventional trabecular meshwork outflow and reducing the episcleral venous pressure. Apart from the two major randomized controlled trials on ROCK inhibitors, the famous ROCKET trial and the ROCK-J post-marketing surveillance trial, there have been few studies in literature. After its introduction in the Indian market in January 2020, there are only a few established publications on Indian patients. So we attempt to analyze the efficacy in South Indian glaucoma patients. The aim of the study is to assess the efficacy of Netazodil in lowering intraocular pressure and to analyze the adverse drug reaction in glaucoma patients over a period of 6 months. As is a retrospective study conducted at the glaucoma clinic of a tertiary eye institute in South India during the study period June 2021 to 2022. Patients who are initiated on Netazodil from the study period June to January 2022 are followed up for a period of 6 months. Data from the medical records at the follow-up visits of 2 weeks, 1 month, 6 weeks, 3 months and 6 months are collected. Patients with age less than 18 years or with congenital or developmental glaucomas are excluded. The analyzed data include demographic characteristics, the type of glaucoma, whether Netazodil was given as a primary or an adjuvant drug, the baseline intraocular pressure and IOP at successive visits, the baseline ocular surface status and the ocular surface adverse effects on the follow-up visits. Coming to the results. Analyzing the 46 study subjects included 30 males and 16 females with a mean age of 65 plus or minus 11 years. This is a pie chart showing whether Netazodil was given as a primary or an adjuvant drug. No patients received Netazodil as a monotherapy and majority of patients it was a third adjuvant. The type of glaucoma enrolled included mainly primary open angle glaucoma, followed by secondary glaucoma, primary angle closure glaucoma. The secondary glaucomas included neovascular glaucoma, steroid-induced glaucoma, and exfoliation glaucomas. The baseline ocular surface status assessment at the baseline visit showed that majority of our patients had pre-existing meibomitis, followed by blepharitis and dry eye with filamentary keratitis. This is a bar diagram showing the adverse drug reaction following Netazodil therapy. Adverse drug reaction after topical instillation of Netazodil developed in 19.56% of our patients, and the most commonest was the conjunctival hyperemia. Not the extent of conjunctival hyperemia in one of our patients who was started Netazodil for steroid-induced glaucoma. The mean intraocular pressure of the study group was 23 plus or minus 8.5 and statistically significant IOP reduction was seen at 2 weeks, 6 weeks, 3 months and 6 months with the maximum reduction at 2 weeks. This is a line graph showing significant reduction of IOP after initiation of Netazodil at 2 weeks followed by a brief rise and plateau effect between 1 to 3 months to a final stabilization by 6 months. This is a dot plot graph of IOP with successive visits showing the IOP distribution around a mean value. From the scatter plot it is obvious that we have taken a lot of secondary glaucomas with extremely high IOPs. Coming to the discussion. When our study is compared with the famous ROCKET 1 and 2 trial and the Japanese trial, the IOP reduction is comparable. Our 1 month IOP reduction is 19.3%, which is comparable with the 1 month reduction of Japanese trial. Whereas the adverse drug reaction in our study group is far less, probably because of lack of documentation as ours is a retrospective study. The major adverse drug reaction reported in our study was also conjunctival hyperemia. So the limitations are, because our study is a retrospective study, there was no clear planned protocol for documentation and there has been documentation failure. And in majority of our patients, our drug was a third add-on, so there was a significant dropout during the study period. Coming to the conclusion, Netazodil is an effective drug as adjuvant therapy in the management of glaucoma with a significant sustained IOP reduction over 6 months. Significant IOP reduction was seen in all glaucoma subtypes and major adverse effects related to the drug were not identified. These are my references. Thank you.
Okay, thank you. Is it a clinical trial or something, part of a clinical trial?
No, sir.
No sponsorship?
No, sir.
Then why you had done a retrospective study?
Sir, the study period, like we have to have some study period was done during this. We analyzed as a retrospective study. So we included those patients. The number of nitazoxanide patients who are on nitazoxanide was far less in our study. So it was only 46. So we have to go back to the medical records to check regarding the IOP at the initiation time, and the adverse effects which are following the initiation has to be got from the medical records. So we have to do it as a retrospective analysis for that.
It is not given as a primary, only second or third drug?
Yes, sir. No one was given as a primary drug.
Then why you take a mix of primary glaucoma, secondary glaucoma, everything mixed together?
Like I took a single consultant, and every single patient who received nitazoxanide during that study period was taken into consideration. So major studies which were done earlier was mainly on primary open angle glaucoma. So but our consultants, which like they have been giving this as a third add-on to patients with the secondary glaucomas and also primary angle closure glaucomas also, who are already on 3 AGMs. So I included them also.
Okay, thank you.
How do you check the IOP in this study?
Goldman applanation tonometer, sir.
Okay.
Good afternoon. I'll be presenting in my topic, which is a cross-sectional study to evaluate the effect of myopia on peripapillary retinal nerve fiber layer thickness, which is measured by optical coherence tomography. And the main aim of my study is to study the pattern of peripapillary retinal nerve fiber layer thickness in myopia. And we know that potentially blinding ocular disease associated with myopia is glaucoma, which is characterized by progressive degeneration of the retinal ganglion cells. And the morphological appearance of optic nerve head in myopia renders the clinical diagnosis and monitoring of glaucoma progression in myopic eyes challenging. And the RNFL thinning associated with myopia may mimic the RNFL thinning associated with the glaucoma, sometimes leading to overdiagnosis of glaucoma. And the objectives of my study are to evaluate the effect of myopia severity on average RNFL thickness and also on RNFL thickness in all 4 quadrants, and to evaluate the average RNFL thickness and correlate it with the axial length of the eye, and to compare any relationship between the central subfield foveal thickness and the myopia varying severity. And this was a cross-sectional observational study which was conducted at Dr. Tony Fernandez Eye Hospital with a sample size of 240 eyes, and time frame was from January 2021 to May 2022. And the myopic patients and also the myopic astigmatism patient in the age group of 16 to 50 years with best corrected visual acuity 6/9 or better was included. And those with a history of glaucoma or IOP more than 21 mm of mercury and cup dust ratio more than or equal to 0.7, and those with prior intraocular surgery or laser treatment, those with retinal diseases, significant media opacity, and a history of diabetes, hypertension, and OCT signal strength which is less than 6 were excluded from the study. And all the patients had undergone a detailed history. Then visual acuity was assessed with the help of Snellen's visual acuity chart, which was later converted to a logMAR chart. And the near vision was assessed, and then a refraction was conducted with the help of a autorefractometer, and also a subjective refraction was carried out, and it was converted to spherical equivalent. And IOP was measured with the help of Goldman applanation tonometry, and slit lamp examination was done to assess any corneal or lenticular opacities, and fundus examination done to assess the cup dust ratio and also retinal macular pathologies, and axial length was taken with the help of optical biometer, and RNFL thickness and CSFT was taken with the help of Cirrus HT OCT. And RNFL was taken in all the average and also all the 4 quadrants, and CSFT was taken as central 1 mm in the macular cube scan. And based on the refractive error, the patients were grouped as low myopes, which those with refractive error less than -3 diopter sphere, and moderate between -3 and -6, and high myopes, which is more than -6 diopters, and each group had equal number of samples, which is 80 in each group. Coming to results of my study, there were 60% of samples were females, and nearly equal amount of right and left eyes, and with age group, maximum falls in the 25 to 40 years age group. And from this data, it is seen that the average RNFL thickness and correlating with the severity of myopia, in average, superior, inferior, and nasal quadrants, it has got a negative correlation, which is statistically significant because the p-value is less than 0.05. But in RNFL thickness in temporal quadrants, even though it shows a negative correlation, it is not that statistically significant when compared to the others. These are the graphical representation which shows a negative trend in the average, superior, inferior, nasal quadrants, but in temporal it shows a negative correlation, but not that statistically significant when compared to others. Coming to axial length, the average, superior, inferior, nasal quadrants show a negative correlation, with a p-value of p-value of 0.01, which indicates it's a statistically significant data, but in RNFL thickness in temporal quadrants, even though a negative correlation, it is not statistically significant. And the graphical representation shows a negative trend in the average RNFL thickness, the RNFL thickness in the superior, inferior quadrants, and nasal quadrant, but temporal does not show a negative correlation. On comparing the severity of myopia with central subfield foveal thickness, it showed a negative correlation, but is not statistically significant. That is, there is no correlation between the severity of myopia and CSFT was seen. Coming to discussion, our study showed that the RNFL thickness decreased as the myopia increased in all quadrants except the temporal, which was similar to that finding seen by the study by Ajay R. Kamath and Saeed Ahmed et al. But in study by Sali et al. Showed that the myopia, as the myopia increased, the thickness decreased in all quadrants except the temporal and nasal quadrants. But in study by Ho et al. And Boyd et al., they showed no significant correlation between myopia and RNFL thickness. And coming to axil length, our study showed that as the axil length increased, RNFL thickness decreased in all except the temporal, which showed a negative correlation but was not statistically significant, which was similar to that seen with Soniga et al. Study and Fahmy et al. Study. But in a study by Rocher et al. Showed axil length increased all the quadrants except the nasal and temporal, but Cerny and Leung et al. They showed a negative correlation in all the quadrants. Comparing the CSFT, we showed does not show a statistically significant relation between the myopia and CSFT, but in Varis et al. Study they showed that as the myopia decreased, the foveal thickness increased, but in Rugas et al. They showed that as the myopia decreased, the foveal thickness decreased there. And the limitations of study did not include any emmetrops in the study, and the wide range of age group is included in our study. In the conclusion, as the severity of myopia increases, the axil length increases, inverse relation is there except in the temporal quadrant. There is no relation between CSFT and myopia, and there is no peculiar pattern of RNFL thinning myopia compared to glaucoma, and OCT is helpful in diagnosing pre-perimetric glaucomatous changes. It should be interpreted with caution in myopes, especially high myopes. And the recommendations are normative database, which is corrective for axil length and refractive error, should be incorporated while interpreting OCT, and it is better to depend not only on the OCT but also on the clinical findings. Thank you.
So, okay, good study. Why you have done the study? You are part of DMB training. Why you have selected this myopia?
There is a close correlation between myopia and glaucoma, so that in some patients it is difficult to understand whether the disc may be larger, so it is difficult to understand whether it is the glaucoma or it is a myopia. So not to overdiagnose or to underdiagnose a glaucoma, myopia, the RNFL pattern in myopia is needed to be known to the doctors.
Okay, finally after the study, what is your summary, what is your conclusion, what is the message you want to convey to the
that is,
audience?
while doing the OCT, it is necessary that we should look on the refractive error and also the axial length of the eyes, so that we do not overdiagnose the glaucoma, or else it may be like, but the pattern is different. In glaucoma, the pattern of thinning is different to that of the, there is no peculiar pattern seen with myopes, but in glaucoma there is a peculiar pattern. In most cases it is followed that pattern, the superior thinning will be there. That is seen in most of the patients.
Can you recommend OCT as a routine for a diagnosis or follow-up of glaucoma? Can you recommend after this study? Cannot. Okay.
Do you know what is red eye disease?
Red eye disease. Red eye disease. Sorry. Thank you, sir.
Good morning. My study is on the study of visual status in patients undergoing silicone oil infusion. Silicone oil tamponade is often used in eyes with a complicated vitreoretinal pathology. It is usually removed 3 to 6 months after surgery. However, the presence of silicone oil accelerates the cataract progression, and this justifies in performing proactive cataract surgery and IOL implantation at the time of cataract removal. Purpose of the study is to study the visual outcome in patients who have undergone vitrectomy with silicone oil infusion for vitreoretinal diseases at various stages of their treatment. Material and methods: retrospective study conducted at a registered eye care center in South India. Data of 50 patients who underwent vitrectomy with silicone oil infusion for various vitreoretinal diseases and then SOR with phacoemulsification and IOL implantation as a second surgery were obtained. Data was obtained from the electronic medical records. Demographic details like name, age, gender, eye MRI number were included. And then the BCVA for distance at the time of diagnosis of the condition requiring vitrectomy with silicone oil infusion, 1 month after the primary surgery, BCVA just before SOR plus IOL, and the BCVA 1 month after SOR were obtained. Inclusion criteria: silicone oil tamponade phakic eyes, patient scheduled for SOR with phacoemulsification with IOL implantation as a single-step surgery. And the BCVA recorded was according to the Snellens and then converted to logMAR values. Data was entered in Excel sheet and analyzed using SPSS software 26. Results: distribution of gender, 58% was seen in the males and 56% of the eyes affected was the right eye. And then the BCVA progression, it was found that the mean BCVA had improved after the silicone oil infusion in a significantly, and then the BCVA progression was decreasing just before the SOR plus IOL. And after the SOR plus IOL, there was significant improvement in the BCVA with a p-value less than 0.001. Distribution of diagnosis, it was seen that more number of cases was in TRD, that is 36%, and RRD had 32% of the cases were RRD. The mean age of the affected sample was found to be 55.64 years, and the mean time for progression of cataract from primary surgery with silicone oil infusion to the secondary surgery, that is SOR, was found to be 10.75 months. 62% showed improvement after the primary surgery, but there was no significant change in BCA with variable duration between SOI and SOR. Hussain et al. Documented improvement in BCV of 6/18 or more in 37% of eyes undergoing SOR. That was a study with 98 cases. And in our study with 50 eyes, 40% achieved BCVA for distance better than 6/18. Kevin et al. Also proposed BCVA improved was more after removal of SO, silicone oil and secondary oil implantation in eyes with poor visual acuity than those with better visual acuity. In our study also, there was significant improvement in BCVA after SOR plus IOL. And the conclusion is that in our study, the final BCVA has shown positive outcome after surgical management, that is SOR plus IOL, after various complicated retinal surgeries. Thank you.
You record only the cataract formation and the visual acuity only. Any secondary glaucoma you estimated?
No, sir.
No, sir.
No.
So how many cases you undergone cataract out of these cases?
So all cases had cataract.
Within one year?
50, yes, within one.
The secondary IOL.
Secondary IOL. Yeah.
So do you done any primary IOL implantation during vitrectomy?
No, those cases were not included. Only the combined cases were included.
So when was silicone removed, during the cataract surgery or before cataract surgery?
During the cataract surgery, the silicone oil was removed. Mean was 10 months duration usually.
Okay.
Thank you, sir.
Why do you test the visual acuity first with the Snellen set and then logmar? Why?
Because for the statistical analysis, the logmar values are used. That continuity will be there, unlike using Snellen's for the analysis purpose. Thank you.
Good afternoon. My paper is on assessment of dry eye using a comprehensive dry eye evaluation tool. I have no financial interest. Deuce 2 defines dry eye disease as a multifactorial disease of the ocular surface characterized by loss of homeostasis of the tear film, in which tear film instability and hyperosmolarity, ocular surface inflammation and damage, neurosensory abnormality play etiological roles. Mainly, two forms of dry eye disease are recognized. They are the aqueous deficient dry eye and evaporative dry eye. These two forms can present as single entities or they may overlap, causing a mixed type of dry eye also. In aqueous deficient dry eye, there is reduced lacrimal secretion in conditions of normal evaporation from the eye, whereas in evaporative dry eye, there is excessive evaporation from the exposed tear film in the presence of a normally functioning lacrimal gland. Our aim was to study the prevalence of various subtypes of dry eye disease in a hospital-based population and to analyze it according to the pathological subtypes and also to study the various risk factors. Ours was a cross-sectional study and we included patients above the age of 18 years who reported with symptoms related to dry eye and who were advised dry eye evaluation. Those with acute ocular surface infections, extensive ocular surface pathologies, ocular surgery within the past 2 months were excluded. We took a detailed history. Symptom score was assessed using both OSDA and DQ5 questionnaire. Clinical examination was followed by a comprehensive dry eye workup, which included assessment of tear film and meibomian gland using non-contact, non-invasive IDRA ocular surface analyzer, tear volume assessment using both Schirmer 1 and 2 test, ocular surface staining using fluorescent and lissamine green to assess the extent of ocular surface damage, lipos and lid viper epitheliopathy grading. Tear film analysis using IDRA measured non-invasive breakup time, meibomian gland loss area percentage of both upper and lower lids, lipid layer thickness, tear meniscus height, and eye blink quality. And finally, patients were classified according to the type and severity of dry eye. Moving on to the result, we enrolled a total of 231 patients and majority were females and the mean age was 53.02 years. Evaporative dry eye was the most common subtype followed by mixed dry eye and majority of patients had moderate severity of dry eye. And all the three subtypes of dry eye occurred predominantly in females and the predominant symptom reported by patients were feeling of dryness followed by itching and burning sensation. On analyzing the symptom severity score, we found that about 66.2% of patients had a normal OSDA score, whereas about 64.9% of patients had a DEQ-5 score of more than 6, which was suggestive of dry eyes. On analyzing the risk factors, we found that about 50.2% of patients used visual display terminal for an average of more than 4 hours, of which more number of patients were in the age group of 18 to 45 years. Evaporative dry eye was the predominant type and incomplete blinking was noted in 60% of patients in this age group. On tear film analysis using IDRA, we found about 76.2% of patients had an NIBUT, that is non-invasive breakup time of less than 10 seconds. 74.5% of patients had lower values of lipid layer thickness and lowest values of lipid layer thickness was found in patients with mixed dry eye. About 59.7% of patients had lower values of tear meniscus height. Patients with evaporative dry eye had more area of meibomian gland loss followed by mixed dry eye and about 67.1% of patients had incomplete blinking. On correlation analysis, we found a positive correlation between OSDA score and meibomian gland loss area and a negative correlation between OSDA score and tear meniscus height. Moving on to the discussion, in a study conducted by Lemp et al., evaporative and mixed dry eye accounted for about 80% and only 10% was aqueous deficient dry eye. A similar distribution was seen in our study also. In another study conducted by S. Chatterjee et al. On OSDA and DEQ-5 score comparison in Indian patients with dry eye disease, they found DEQ-5 scored symptoms higher than OSDA questionnaire. In our study, we found number of patients diagnosed with dry eye disease using DEQ-5 questionnaire was higher than using OSDA questionnaire. In another study conducted by Woolson J.S. et al. On risk factors for dry eye disease, they found that greater digital screen exposure was found to be a predictor for evaporative dry eye. In our study, in about 60.8% of patients with evaporative dry eye, there was a reported usage of visual display terminal for more than 4 hours. In another study conducted by Wei Feng et al. On morphological changes in the meibomian gland using infrared meibography, they found a large proportion of meibomian gland dropout cases among patients with dry eye disease. In our study, about 64.5% of patients had a meibomian gland loss area of more than 40%. So to conclude, there is a high prevalence of evaporative dry eye with a female predominance in all the three subtypes of dry eye. DEQ-5 questionnaire was found to be more sensitive for assessing symptom severity compared to OSDA score. Visual display terminal use for more than 4 hours was found to be an independent modifiable risk factor for evaporative dry eye. Positive correlation between OSDA score and meibomian gland loss area and a negative correlation between OSDA score and tear meniscus height indicate that loss of meibomian gland and poor tear meniscus height are directly associated with dry eye symptoms. These are my references. Thank you.
The study was done as a questionnaire or physical examination?
Physical examination.
With the questionnaire also?
Yeah. With both OSDA and DEQ-5 questionnaire and also physical examination.
But the age is varying from 18 to 88. Age-wise, have you done any analysis? Age group?
No.
No, because 88 and 18 has no comparison. That's why.
Sir, we included the patients who reported with symptoms of dry eye. Those came with symptoms of dry eye.
18 age people are also coming with a dry eye?
And also,
with the computer vision syndrome, anything? What is computer vision syndrome?
Computer vision syndrome.
Usually 18, 20 means usually will...
seen in more patients who are using visual display terminal for more hours.
Have you done an analysis based on occupation of the patient? Any analysis? Especially evaporative. Those are sitting in this room are more dry eye. Those are sitting in the air hole because air hole has good AC. Here there's no AC. So that's
Occupation-wise, we didn't, but we analyzed what type of visual display terminal they are using and how many hours they are using.
okay, good.
The evaporative dry eye common in females, you noticed. And is there any females? And they are working group or not?
Occupation we didn't analyze.
Okay.
Good afternoon, everyone. I'm presenting the study on comparison of optic nerve head changes in patients with thyroid orbitopathy and age-matched normal individuals. The background of the study, thyroid eye disease affects 25 to 50% of patients with Graves' disease, and around 3 to 7% develop vision-threatening complications such as optic neuropathy. Optic nerve was evaluated clinically in terms of visual acuity, color vision, pupillary reaction, and visual field, and optical coherence tomography is a more reliable and reproducible tool for assessing the anatomy of the optic nerve. Retinal nerve fiber layer thickness has been proved to decrease in patients with thyroid eye disease who had no clinical sign of optic neuropathy, which indicated structural damage might occur earlier than functional impairment. The objective of the study was to analyze the optic nerve head and macular changes in patients with Graves' disease using OCT and to investigate the association of Graves' disease and intraocular pressure. It was a cross-sectional study for a period of 2 years in eyes of patients with Graves' disease, and 64 eyes of 32 patients were taken by based on a study by Guo et al. With 80% power and 95% confidence. The minimum sample size was 64. The inclusion criteria: patients included in the study were diagnosed with Graves' disease with no evidence of optic nerve compression clinically based on visual acuity, pupils, color vision, visual field assessment. And the exclusion criteria were patients with significant cataract and media opacities with OCT scans of signal strength less than 5/10, conditions known to be associated with retinal nerve fiber layer abnormalities, glaucoma and other optic disc changes, and myopia of more than -3 diopters and hypermetropia of more than +3 diopters. 32 case and 32 controls underwent the following tests of best corrected visual acuity, color vision, contrast sensitivity, refractive errors, intraocular pressure by applanation tonometry in straight gaze, 90D lens examination, fundus examination, HFA, optical coherence tomography for retinal nerve fiber and macular thickness, and clinical activity score in patients with thyroid eye disease. The statistical analysis was IBM SPSS version 26. The results based on the gender distribution, 37% were male and 63% were female in cases, and in the 32 eyes of controls, 44% of them were females and 56% of them were males. The age distribution in cases, the mean age in cases was 43.5 years and the mean age in controls is 47 years, and the range was between 18 to 65 years of age. Functional optic nerve assessment, visual acuity in cases and controls was 0 by logMAR, and color vision and contrast sensitivity in cases and controls was normal, and the clinical activity score in cases was 1.12 with a standard deviation of 1.2. Hertel's exophthalmometry, there were 59% of them had a Hertel's exophthalmometry value of more than 21 millimeters and 41% had less than 21 millimeters. Coming to the retinal nerve fiber layer thickness, there was thinning in the retinal nerve fiber layer in the cases in the nasal and the temporal quadrants, and the values in the temporal quadrant were statistically significant. In the inner macular ring thickness, there was thinning in the inner macular ring thickness in the nasal and the superior quadrants in cases as compared to that of controls. And in the outer macular ring thickness, there was thinning in the all the quadrants in cases as compared to that of controls, and the thinning in the nasal and the superior quadrants was statistically significant. The mean intraocular pressure in case of cases was 19.5 mm of mercury with standard deviation of 2.51, and in controls was 18.84 with standard deviation of 2.83. Ocular hypertension, there were 10 eyes, that is 31% of them, who had intraocular pressure of more than 21 mm with no associated retinal nerve fiber layer changes or optic nerve head changes. Patients with thyroid ophthalmopathy were compared with age-matched normal individuals, and the mean intraocular pressure measured by applanation tonometry of cases was higher as compared to that of controls, and this difference in the IOP could have been caused by relatively increased intraorbital contents in the study group. Out of the 32 eyes, 19 eyes, that is 59%, had an exophthalmometry value of more than 21 millimeters, and out of these 19 eyes, 9 of them had an increased IOP of more than 21 millimeter measured by Goldman's applanation tonometry in straight gaze. comparing the study to other studies, in a study by Sayan et al., the difference in the inferior RNFL values was found to be statistically significant, and a study by Ibrahim and Menoufe et al., there was no significant difference between the two groups. And in our study, there was a difference in the temporal quadrant, which was statistically significant. And coming to the inner and the outer macular ring thickness, in a study by Sayan et al., the thinning was observed in the inner macular thickness, inner and outer macular thickness in all the quadrants, and a study by Ibrahim and Menoufe et al., the inner and outer macular ring thickness was increased in cases compared to that of controls. And in our study, there was thinning in the superior nasal quadrants in both the inner and the outer macular ring thickness. And coming to ocular hypertension and comparing our study to other studies, in a study by Kalman and Morut et al., out of 482 samples, 4.8% had ocular hypertension, and in a study by Kogoheim et al., out of 500 eyes, 24% of them had ocular hypertension, and a study by Silva et al., 107 of them were studied and 3.7 had ocular hypertension. In our study, out of 32 samples, 31% of them had ocular hypertension. In this study, it was found there was temporal nerve fiber layer thinning, superior nasal macular thinning as compared to the control group, and it was found that intraocular pressure was higher in patients with increased proptosis, and it is also found that in patients with Graves' disease, there is thinning in the RNFL and macular thickness. This indicates structural changes occur before functional changes or other clinical signs. These are my references. Thank you.
Okay. Are you combining together the thyroid disease with ocular hypertension, or two categories separate? How done the study?
32 samples were taken, sir, and out of them, the people who had an intraocular pressure of more than 21 millimeter was also studied.
What's the division? All patients have ocular hypertension? Or
not all patients had ocular hypertension, sir. Only out of them, 59% of them had increased. So 31% of them had increased ocular hypertension.
Why you brought the ocular hypertension to thyroid also? Why?
Because increase in intraorbital contents can cause increased IOP, which can later cause glaucoma also. So then,
then what is your final conclusion?
That increased thyroid eye disease is associated with increase in intraocular pressure.
Okay, so you should do a glaucoma screening also.
Yes.
How do you make the diagnosis of thyroid ophthalmopathy in this case?
It can be based on clinical activity score based on all endocrinological and other immunological findings.
Any imaging? No.
Imaging CT, MRI can also do USG.
In your study?
In my study, I didn't do USG, so based on clinical activity score and also based on immunological and endocrinological findings.
Okay.
Good afternoon, everyone. Glaucoma is one among the leading causes of irreversible blindness around the world, and by early detection, the visual field loss can be prevented. Early detection of glaucoma by optic nerve damage is really challenging. The universal population screening for glaucoma has not been demonstrated to be budget friendly, so the current practice restricts the case finding to high-risk groups only. Many risk factors have been identified for primary open-angle glaucoma, but only a less number is well supported by evidence. So, this study, the aim is to identify the relation of myopia, central corneal thickness and corneal curvature with primary open-angle glaucoma with specific objectives of determining axial length in primary open-angle glaucoma patient as a measure of myopia, and to determine central corneal thickness and corneal curvature in patients with primary open-angle glaucoma. This was a prospective cross-sectional observational study held at Ophthalmology Department in a tertiary care center in Kerala over a period of 1 year. The study population had two groups. Group 1 was eyes with primary open-angle glaucoma in patients above 40 years of age, and Group 2 was eyes without primary open-angle glaucoma in patients posted for cataract surgery. A sample size of 88 eyes in each group was calculated according to the findings from the parent study. Patients with scarred cornea and those who have undergone previous ocular surgery were excluded from the study. After taking informed consent and detailed ocular examination, the axial length was measured using ultrasound A scan, corneal curvature using the autorefractive keratometer, central corneal thickness measured using anti-segment OCT. All the data obtained was entered in Microsoft Excel sheet and analyzed using the SPSS software. Coming to results, a total of 176 eyes of 88 patients were evaluated in the study, and there were 88 eyes in each group. The mean age was almost similar in both groups, ranging from 49 to 72 years in the POAG group and ranging from 46 to 80 years in the control group. Both groups had more males, and the percentage being higher in the primary open-angle glaucoma group. In the study, it was found that the central corneal thickness in primary open angle glaucoma group patients was significantly lower when compared to the control group. It was also found that the axial length in primary open angle glaucoma group was significantly higher when it is compared to the control group population. The average K value in the primary open angle glaucoma group was found to be significantly lower when it is compared to the control group. Also, systemic associations with primary open angle glaucoma was also evaluated. It was shown that hypertension and diabetes mellitus was significantly associated with primary open angle glaucoma. Other systemic conditions such as thyroid disease, cardiovascular diseases were not significantly associated with primary open angle glaucoma in this study. So coming to discussion, in this study it was found that longer axial length, thinner central corneal thickness, low value of average K value was found in primary open angle glaucoma group patients when compared to the control group. These results were almost similar to the results by a study by Vijayapai et al. And the Los Angeles Latino eye study, only that those studies central corneal thickness was not evaluated. The Los Angeles Latino eye study suggested that patients with myopic refractive error, longer axial length and flatter cornea were at high risk of developing primary open angle glaucoma. The Singapore Malay eye study suggested that patients with axial myopia and increased axial length are associated with primary open angle glaucoma. In ocular hypertension treatment study, no association was found between myopia and primary open angle glaucoma, but it was disclosed that thinner central corneal thickness may be a predictor for development of primary open angle glaucoma. Other population-based studies such as Blue Mountain eye study and a study by Ling Shen et al. Also suggested that myopia is a risk factor for primary open angle glaucoma. So to conclude, axial length, central corneal thickness and corneal curvature showed significant association with primary open angle glaucoma when compared to the control group in this study. The axial length in primary open angle glaucoma was higher than the control group, suggesting axial myopia as a risk factor for primary open angle glaucoma, and patients with primary open angle glaucoma had lower central corneal thickness and flatter corneas when compared to the control group. Diabetes mellitus and hypertension were found to have association with primary open angle glaucoma. These are my references. Thank you.
Almost all these points are non-factors. Anything new from this study?
It was done in population in Kerala.
That's only. Okay. Finally, you said there is association with diabetes and hypertension. What is association? High risk or what is association? Previous slide. Last but one.
In primary open angle glaucoma group, there was more diabetics and hypertensive patients when compared to the control group, and it was significantly associated.
It is related to age. Usually people will old age. It is age match control and.
Not age matched.
So maybe old age. Maybe.
How do you check the axial length?
USG-A scan.
Yes. Okay.
Thank you, sir.
Good afternoon all. My paper's title is Retinopathy among patients receiving hydroxychloroquine based on OCT and HFA. Introduction. Retinopathy is any damage to retina which cause visual impairment. The role of systemic medication in causing retinopathy is very important as it is a preventable cause of blindness. HCQ is an anti-malarial drug used extensively in the treatment of autoimmune diseases. Retinal toxicity is the major and irreversible side effects of HCQ. High dose and long duration of use are the significant risk factors for developing retinopathy. AAO and Royal College of Ophthalmologists guidelines recommend the use of both automated visual field and spectral domain OCT for routine primary screening because they are widely available. Subjective screening tests like automated visual field and microperimetry, objective screening tests like SDOCT, fundus autofluorescence and multifocal electroretinogram are used. So coming to the objective, to detect the retinopathy among patients receiving HCQ and based on OCT and HFA. Materials and methods. Study design is a descriptive study. Study period is from March 2021 to March 2022. Study setting is Department of Ophthalmology, Government Medical College, Kottayam. Inclusion criteria, all patients aged above 18 years who are being treated with HCQ for more than 1 year attending ophthalmology OPD at Government Medical College, Kottayam during this study period. Exclusion criteria: all patients with non-macular disease are excluded. Patients with media opacity which inhibit the OCT examination and visual field testing are excluded. Patients who are already taken retinotoxic drug also excluded. After taking a well-written informed consent, all patients underwent complete ophthalmological evaluation. Objective test used in my study is SDOCT, that is Topcon Mastero, and subjective test is automated threshold visual field testing, HFA. Based on the spectral domain OCT finding and visual field testing, the cases were grouped into no retinopathy, possible retinopathy and definitive retinopathy according to Royal College of Ophthalmologists guidelines. No retinopathy means no abnormality suggestive of toxicity depending on any test. Possible means one test results typical of HCQ retinopathy but typical abnormality is not present in the other test. Definite retinopathy, both subjective and objective tests show abnormality. So coming to the result, out of 120 patients, 73.3% of above 40 years of age. And gender distribution, 90% of patients were female. Coming to the cumulative dose, 70% is having a cumulative dose of less than 500 gram and 27.5% have 500 to 1000 gram and only 2.5% have more than 1000 gram. This is the proportion of retinopathy that is found in my study is 5.8%. That means 7 out of 120 patients have retinopathy. Proportion of retinopathy, out of these 7 patients, 4 were having possible retinopathy and 3 having definitive retinopathy according to the criteria. Among 7 patients found to have retinopathy, 4 having bilateral disease also. So this is the 7 patients list where the vision was 6.6, that is the best corrected visual accuracy was 6.6 in 3 patients and 4 were asymptomatic. The duration is more than 4 years up to 8 years in these patients, and also the cumulative dose is more than 500 in all of these patients, and for one patient it is more than 1000 gram. So this is the OCT findings where the patient showing parafoveal thinning in bilaterally for one patient, foveal thinning plus disruption of ISOS junction is for 2 patients unilaterally. Parafoveal thinning and disruption of parafoveal ISOS disruption is seen bilaterally in 1 patient. Foveal thinning and ELM disruption is seen in 2 patients bilaterally. Totally 3 patients with structural abnormality noted in unilateral and 4 patients in bilateral. This is the HFA finding where 10-2 showing paracentral scotoma in 3 patients and 24-2 showing field defect in only 1 patient. So coming to the discussion, in my study, the proportion of retinopathy is 5.8%. The literature review after 2000 revealed that the proportion is ranging from 0.65% to 7.5%. There is no trend in HCQ retinopathy was noted when the age group is considered. The similar observation was noted in US-based study conducted by Wolfe and Marmer and in California-based study by Mellis and R.B. et al. In my study, those who are taking 400 mg per day dose and duration more than 5 years showed an increased frequency of retinopathy. Similar observation was stated in the study conducted by Wolfe and Marmer and Goldis, Espander et al. So conclusion, to detect the retinopathy among the patient receiving HCQ, it was found that 5.8% of study population has HCQ retinopathy, out of which 3.3% had bilateral disease and 2.5 had unilateral disease. Out of 7 patients with HCQ retinopathy, 3 had definite toxicity and rest had possible toxicity. Out of 7, 3 patients has best corrected visual acuity 6/6 but features of retinopathy. From this, we can suggest that there is no gross defective vision in patient detected to have retinopathy in the study. Now, this may be probably due to the timely screening of the patient on the chronic HCQ usage and detecting retinopathy at its subclinical stage. Retinopathy caused by HCQ is an irreversible condition that lacks appropriate treatment, and it is utmost important to detect the same at the early stage. The OCT along with visual field testing is crucial in detecting early features of toxicity. So as a preventive measure, the drug can be stopped and an irreversible blinding process can be halted. This study is a step forward in timely screening the patient on HCQ and detecting the definite features of retinopathy. These are my references. Thank you.
Okay, good study. Have you done a comparison with the visual field also? Only OCT only?
No, both visual field and OCT.
Okay. And out of 3 patients, out of 7, only 3 patients have no visual acuity affected.
3 patients, no visual acuity affected, but retinopathy is present in that patient.
So what advice you give in that patient? Can you discontinue or? What is
Not dose modification is dose modification.
Dose
Not discontinue because autoimmune diseases are also very
Okay,
important.
that means I reduce the dose or
Reduce
something.
the doses.
Okay. Okay, good.
Is it OCT or HFA? Specific, more specific and sensitive?
In this study, OCT was very specifically noted. All these changes were noted in OCT.
Okay.
Good afternoon all. My research is titled A Longitudinal Observational Study on the Effects of Prolonged Use of Anti-Glaucoma Drugs on the Ocular Surface. What is the relation between glaucoma and ocular surface? IOP continues to be the only risk factor which can be treated in glaucoma by medical or surgical means. Anti-glaucoma medications are meant to be used for lifelong and require strict adherence, and the adverse effect hence has to be minimal so that the patient remain compliant and continue the therapy. So what happens if OST does occur due to anti-glaucoma medications? The compliance will be impaired, there could be treatment failure, there could be progression of the glaucomatous damage, and regarding surgical aspect, there could be long-term conjunctival inflammation causing subconjunctival fibrosis, resulting in failure of filtration surgery, and with both failure of medical and surgical measures, we could be facing the dreaded permanent loss of vision. This is where the study becomes relevant. The purpose of the study is to determine the incidence of ocular surface disease in newly diagnosed cases of primary glaucoma, both open and closed, who have been just initiated on topical IOP lowering therapy. Objectives of the study: the incidence of OSD was analyzed in newly diagnosed patients of glaucoma initiated on topical therapy within the last 3 months. The incidence was compared between those using single drop therapy versus multiple drop, and we studied the association of preservatives used in anti-glaucoma medications and their resultant OSD. This was a longitudinal observation study conducted at Comtesse Charitable Eye Hospital. We recruited 100 eyes of primary glaucoma patients recently diagnosed within the last 3 months, and the time frame was between January 2021 to December 2021. We included patients with primary glaucoma more than 40 years old who have been started on anti-glaucoma medications within the last 3 months. We excluded patients who were less than 40 years and more than 80 years, those with already pre-existing ocular surface disease or using lubricant eye drops in the preceding 3 months, secondary glaucomas, and all the other causes, other causes of dry eye, such as previous ocular surgeries, receiving ocular treatment for causes other than primary glaucoma, contact lens users, lid disorders causing incomplete eye closure, history of conditions resulting in tear film spreading unevenly, such as proptosis pterygium, thyroid eye disease, history of any chemo radiotherapy. Now, after recruiting these patients and getting a detailed medical history, including anti-glaucoma drug usage, we subjected them to an OSDI questionnaire. Then we evaluated them on slit lamp. Then shimmer test and tear film breakup was tested. And then they were stained with fluorescent and lissamine green. And then finally, OSD resultant was graded according to the Dew's grading scheme. This is the OSDI questionnaire, which was developed by Allergan. 3 components are measured, including ocular discomfort, function, and environmental trigger within the last 1 week recall period. The scores that has been obtained was then converted using the formula shown, and then based on the result, they were then finally graded according to normal 0 to 12, mild 13 to 22, moderate 23 to 32, and severe 33 to 100. This is the Dew's dry eye severity grading scheme developed in the International Dry Eye Workshop in 2007. So this is a timeline of our study. After recruiting the patients, there was a first visit was for the recruitment. Then the first follow-up, that is the second visit, was done 3 months after recruitment. And the second follow-up, which is the third visit, was done 6 months after the recruitment. And then data was analyzed. Results and discussion. We found that a staggering 96% of our study population developed OSD by third visit. The role of active drug ingredient, we found that bimatoprost presented a 50% chance of developing OSD, followed by timolol at 32%. We've also found that 13% of patients using timolol did not develop OSD even by third visit. This was generally in agreement with previous studies, such as the studies conducted by Chen et al., who found that increased risk of dry eye was observed for all glaucoma medication, and another study was conducted by Arita et al., who found that meibomian gland loss was found in both prostaglandin-treated eyes as well as in beta-blocker-treated eyes. Regarding preservatives causing OSD, the drugs that we had given to the patient, 60% of patients had benzalkonium chloride, oxychlorocomplex in 24%, and 6% of our patients were using non-preserved drugs. We found that 100% of patients using preserved drugs developed OSD. And we also found an interesting finding is that 8% of patients on preservative-free drug also developed OSD, which we could hint that the active drug ingredient could also be a role in playing OSD, and preservatives may not always be the culprit. This was generally in agreement with previous studies conducted by Pisella et al. As well as by Jenian et al., who both concluded that symptoms and signs are less prevalent when preservative-free drops are used, and that the adverse effects which were caused by the preservatives are reversible after removing the preservatives. We also found that OSD occurred earlier in patients who were on multiple preservatives. They were also found more in patients using multiple drops as compared to single drops. Then increasing incidence was found in single drug users, and the clinical symptoms and signs were progressively worsened by third visit. OSDI score showed a significant value by third visit. And then we conclude that ocular surface disease in the mild to moderate form is a significant problem faced by glaucoma drug patients, and prostaglandin analogs followed by timolol was found to be more associated with OSD. Preservatives was found to be a culprit. Multiple drop was also found to be a culprit. The limitation of our study was that various generic brands were used, so the concentrations of drug and preservatives were non-uniform, and equal number of drug was not analyzed. We recommend that routine evaluation of OSD be done in glaucoma patients. We need to limit the exposure of ocular surface to preservatives, and if need arises, we need to resort to surgical measures. When the treatment without prevention is simply unsustainable. And with this, I would like to thank you.
Okay, good study. But
Thank you,
how can you conclude that preservative-free also only 8% has a OSD?
Yes, sir.
On the other hand, other has 100% OSD.
Yes, sir.
So preservative-free is comparatively safe.
It's comparatively safe, but we've always believed that preservative was the first which caused OSD, but we need to now start thinking that the active drug ingredient could also be playing a role in causing OSD.
Okay.
Further study will be required.
What is the maximum follow-up? 3 visit means what is the maximum follow-up?
After recruiting the patient was followed up to 6 months. 3 months from the first and 6 months from the first visit recruitment.
Okay, single drug, 2 drug, 3 drug, what is the comparison?
We have we've analyzed all sorts of numbers of frequency of drugs, and we found that the single drug users were less likely to have OSD as compared to multiple drug users. Drop users.
Oh, okay.
How do you exclude the pre-existing OSD?
While recruiting the study, actually the analysis of OSD was done at each of these visits. The first visit was a recruitment visit. So during the recruitment visit, if while analyzing the Tierbert or Schirmer or any of these tests, we found that patient was having significant OSD, we excluded them from the study. That is how it was ruled out.